Rick, this is Peter. Can you hear me?
We can hear you, and your mentee Corey is on the telephone.
I was going to introduce you to him. Have you already talked to him?
Well, very briefly.
Yeah, he's on in regards to his dad, who's been got advanced disease and been fighting it for the last 10 years with various things. He's from Buffalo, New York.
Right.
And it's advanced pretty seriously at this point.
Right. Let's see. Okay, I'm just looking to see if we've got anybody that I've missed. So we've got Tebow, Jake. Write Jake down.
And is back, by the way.
Oh, I don't know what that was. Hey, Ken, how are you?
I'm good, thanks.
Good.
How are you?
Good. We have 3 Arizonans on the call today. How about that? We're taking over.
I'll be dang.
Well, the thing is, that guy in Maui thought he was making a takeover for the call, and he was stacking the call with all these Mauians. That's what we call them. But now we're coming back from Arizona.
I don't think that's a good thing.
Hey, Neil Iannone checking in.
Who was that?
Neil Iannone in Atlanta.
Oh, hello, Neil. How are you? I'm glad you're on the phone because I want to get a little conversation going between you and Ken Anderson. Go on.
Okay.
Because the 2 of you have a very similar situation, and I think I just wrote to Ken earlier on today. You are probably in the place that Ken was in about 4 or 5 months ago, so Ken can help you a great deal.
Okay. He's I'm where he was, you said 4 or 5 months ago?
You are where he was about 4 or 5 months ago, yes.
Okay.
So I think
Great.
that will be helpful. All right, well, look, since we have aggregating here, but I think let's start with Corey, who can talk to us a little bit about his dad, and we can see what we can come up with. Professor Bill isn't on the call yet, but he may well be. He comes in a little bit late. Corey, why don't you, are you also in Buffalo, or is it just your dad who's in Buffalo?
No, I'm in Buffalo. I live a few doors away from my dad, so I've been doing all his caregiving and all his appointments and doctor visits and all his healing stuff for the past, I don't know. He had a big flare-up of his cancer last summer, right around this time.
Yeah.
Before that, he really wasn't in the mindset of cancer until about 7 years before that. He had prostate cancer. He had a prostatectomy about 10 years ago. Then I guess at the time it was a stage 3 cancer with a Gleason score of 8. But at the time I don't remember the doctor ever talking about the Gleason score. I just remember last January it coming up into conversation looking back at his medical records. So I really wasn't even aware of that at the time. But he had a prostatectomy, and then maybe a year or 2 later the cancer started coming back. He did about 38 radiation treatments at Roswell Park Cancer Institute, where Professor Bob is located. And then maybe a year later, it showed signs of coming back again, and they wanted to do chemo and stuff like that. And my dad didn't want to do that. So he kind of broke away from the traditional cancer treatments, and he went a holistic route with an iridologist and a holistic practitioner in Buffalo, and he did like a very, strong, like a healing program with a lot of different herbs and supplements, and, changed his diet to, like a vegan diet and everything. And so he was cancer free after that. All his scans came back clear, but he never followed up with an oncologist or anything. He kind of was just going to the beat of his own drum. He's kind of a unique man, kind of a character in his own way, but a very sweet and dear man. So he was just living his life the past 7 or 8 years, just living life to the fullest. He thought he was cancer free. He wasn't really following up with doctors or anything like that. And then last summer, he had an episode where he was out swimming about 2 miles out in Lake Erie. He loves to swim, and he was really short of breath. And then he was complaining of chest pains and stuff like that. So we went to an emergency room to get him looked at, and then they found enlarged lymph nodes, and they admitted him into the hospital. And then by the end of the visit, the doctor came into the room and said that his PSA was 630. And, it was most likely, obviously, that he had cancer, spread throughout his body or whatnot. So after he did his PET scan and everything, it showed that the cancer was in his pelvic region. It hadn't spread beyond that. It was just like in the sacral area, the pelvis. And so he immediately went back on his holistic program of healing and herbs and diet and stuff like that. And then within a month, his PSA dropped to 400. By the next month, it dropped to 200. Then he started up with an oncologist in Buffalo, and he did Lupron injections. And then it seemed to be working well for him, although he was, really complaining a lot of, not feeling good and having his legs feeling very heavy and pain in the legs, and he wasn't liking that. But to make a long story short, his PSA was down to about 30 in April. And then by June or July, we did another blood test, and the PSA was up to 90. Then by August, it was back up to 200. So it looks to me that the Lupron isn't working any longer. And so now he did a PET scan. And can everyone hear me? I just want to make sure that I'm on the line.
Yep.
Okay.
Yes.
So he did a PET scan, maybe a month or so ago. It showed that the cancer, is more aggressive in the sacral area again. And it's also in the spine now, in a few of the columns of the spine. And so over the course of the winter, he did radiation on the sacrum because he lost control of his bladder and his bowel over the winter. But after his radiation treatments, he was able to regain that. So he was, functioning normally as far as that goes. But he's just finishing up his 15th radiation treatment on Friday. They treated the sacrum and the spine. And then we're kind of, right now we're in the process of exploring what our next options are. The one, both, we've had 2 opinions from 2 different doctors, one at Roswell, one the doctor that he's with now, and they both are suggesting the same course of treatment, which is Zytiga. And then, I have some questions and concerns about the Zytiga, as does he, but we're most likely are going to start it, but I didn't want to put him on it right now because he has a hard time handling radiation. So I wanted to get him through the radiation treatments and then start him on that when he was feeling a little bit better, because he really took his body took a bad toll this summer. He was swimming and doing all his normal activities up until about August, and then he really started to slow down and, was requiring assistance with, like walking, and he couldn't get down to we live right on Lake Erie. He couldn't get down to the beach to go swimming, and just his quality of life has really diminished. But the radiation does seem to be helping. He seems to be walking better and not in as much pain as before. So that's good. The only other thing that's developing is that in the past month, I connected with my friend from Toronto, whose brother had cancer, and he said he treated it in Mexico with a doctor from Tijuana named Dr. Francisco Canez. And I've been in contact with him over the course of the past month, and I have a really good feeling with him. I was planning on taking my dad to Tijuana for a 30-day program. They do like holistic, a 30-day holistic program of like vitamin C IVs and sodium bicarbonate IVs and Laetrile, B17 IVs, chelation, and then they do some other things with it, like a liver cleanse, a kidney cleanse, a colon cleanse. And then they also have different cancer drugs that are available in Mexico that you can't get in the U.S. So I was talking to him about some of those. One is called Rigvir. It's a virotherapy drug that it's not approved in the U.S., but I know a friend of mine that went to Mexico to do that for his prostate cancer, but it was an earlier stage cancer, but he had success with that drug. So anyway, I'm looking at the end of the month on October 28th, the Mexican doctor, because my dad cannot travel to Mexico, he agreed to come to Buffalo and spend 5 days with him and observe him and, look at all his medical records and then, help him start the 30-day program with the help of a nurse, which would be my dad's sister. She's a nurse, so she would administer the daily IVs and everything like that. So I have a good feeling about it. I feel like it will give my dad some life back and some quality of life back. So that is something we're planning on doing. It's $6,000 for the month of all the medications and IVs. So that's kind of on the table now. And then the Zytiga is on the table. And then that's about it at the moment. I've had some other people talk about these, I forgot what they're called, but they're a type of drug that, I can't remember what it's called. What is it called, Peter? The inhibitors or whatever.
I'm not sure what you're referring to. You might mention also that he offered chemo, but he didn't want to do chemo, correct? He
was never offered chemo. None of the doctors have ever really suggested it. I know it's an option if we wanted to do it, but it's never been talked about at this point. I've had some people say that you can do it, like as soon as possible. But we went to Roswell, and that doctor didn't suggest doing chemo right now. And then the oncologist we had didn't suggest doing chemo. So chemo isn't really something I don't think he would want to do anyway. So.
Well, he has to decide. Corey, the first thing he's got to decide is whether he wants to address this disease full on and live life for the longest that he can, or if he wants to putz around with alternative therapies.
Mm-hmm. Right.
And if his decision is he wants to be around for as long as he can, he's got to take into consideration the treatments that we know work. Now, how old is your father? You haven't mentioned age at all.
Oh, he's 69.
He's currently 69, so he's a young man still.
Yeah.
So he was diagnosed when he was what, 59?
59.
Right.
Yeah.
Right. And have you gotten yourself checked?
Yeah, I did this past winter. I got a PSA test and it looked normal.
Okay, well, you just keep doing that at least every year because you're at high risk.
Yeah, I will.
So now, there's a few things. We'll throw this open because I'm sure there's a bunch of guys that have some thoughts. First thing I recommend you do is did you join us on the telephone or did you join us on the internet?
I'm on my cell phone.
Okay. So Peter will, please, Peter, if you would just copy that link and send it to Corey because I don't have an email address. But I put a link in the chat window for a brief discussion by a doctor who reports a study that came out last year that says that the people that follow alternative medicine, the death rate and the prognosis is a lot worse than those who follow conventional medicine. Now, it's interesting.
Right.
I've just been having a discussion. I live in southern Arizona, and most integrative medicine, if you know what that was, all stems to Andrew Weil and the University of Arizona Integrative Medicine Center. Almost all the integrative medicine doctors around this country at some point or another have studied here or came out of here. It was the original integrative medicine center. And I know one of the professors, and we were talking about this just over the weekend. And it's really important, and I'm a great supporter of complementary medicine. I am not a supporter, nor do I encourage alternative medicine. And if you want to follow alternative medicine, God bless you, but it's not something I would ever do, or if I was asked, I would ever encourage anybody to do, because it has no evidential basis. But there are a lot of people who think they're better off without certain invasive treatments, such as radiation or surgery. Your father may have had cancer beating this disease, but the fact that he went from, I mean, I was diagnosed also with Gleason 8 and T3 disease back in 2007. And at the time, I chose to do 2.5 years of Lupron. And it worked. Now, I also know men who did not choose or couldn't follow through for whatever reason, and with their hormone therapy, and their disease came back, and they've since had to go through treatment. So your dad at 69 could have another 20 years of life ahead of him, but not seeing a doctor from Mexico who's going to give him colon cleanses, at least in my opinion, and
right.
You know,
Do you feel that somebody with stage 4 cancer that spread into their bones could live 20 years after finding that out?
I think somebody with stage 4 cancer with it in their bones, the way your father has responded, may have a good chance of living 5 to 10 years. I don't want to say 20 years, but the that I was referring to was if at 59 he would have done that, he would have.
Well, why do you feel he's responding well if the Lupron doesn't seem to be working anymore?
Because he had a PSA of 600, 630, and it drove it down pretty quickly to a low number, and he did quite well on it for a while. Now the Lupron isn't going to maintain the disease anymore. He's through the Lupron. But what I'm saying is that we know now the early Lupron and early chemo. I mean, he was offered chemo back in 2009 or 2010, as you mentioned.
Yeah, he was.
That was radical. Whoever offered it to him in 2009 and 2010 was offering pretty radical treatment if there was no evidence of metastasis. But today, we know that early chemo is very beneficial, certainly to men who have metastasis, and maybe even to men who have suspected metastasis. Similarly, we know second-line anti-androgens, whether they be enzalutamide or abiraterone, are very good. Now, do we know whether they're both good at the same time? There's still a lot of debate. You should listen to the discussion between Chuck Ryan and Alicia Morgans that was put on Euro Today a couple of weeks ago. I have that. In a minute, I may be able to put it in the chat window. And Alicia Morgans' discussion. But we know that these are things that work. In addition to that, all the complementary stuff that he's doing is great. And provided that his genitourinary medical oncologist approves of all these additional drugs, because some of them have all these additional supplements, because some of them have interactions, he could continue doing that. What do I think about, coffee enemas? Not a lot. And the problem is that these doctors come in and say they had this success, they had that success, but then you find, well, these people weren't that sick. Like you say, the guy that went down and got this viral immunotherapy was at a different stage in his disease. So,
I hear you.
To spend $6,000 on a flyer like that, if you've got money to burn, send some of it our way, make a donation. Because, we need that money as much as those doctors who are selling this thing, so we can continue doing the work that we're doing. But to me, I'm just being really frank with you. I find it hard
Yeah.
to to give um, genuine is the wrong word. I find it hard to give personally to give serious support to somebody who discounts. Um, and I'm not saying you're discounting it because you're asking us about Zytiga, but you have to be accepting the medicines that we know work, whatever their side effects are.
Right.
You have to go with the program. And then on top of that, do as much of the complementary medicine as you can tolerate and you want to do. And your dad's doing good
Right.
stuff.
I hear you.
He's exercising, which is great. He's got good diet, which is great. You know, he's hopefully leading a low stress life, living on the lake. But all of this stuff is really important. But nothing is more important than following the protocols that we all know make a big difference to a lot of men.
Yeah. I hear you.
Let me
Thank you.
let me throw it open, guys. Who would like to chip in their 2 cents?
Well, maybe
Now,
could I start? Could
yeah.
I start out with a question about Zytiga?
Sure.
My only concern was one of the concerns about it was that I went onto their website and I was reading about the clinical study that they, talk about on their website. And it just doesn't seem like a very impressive study to me. It says that men who did Zytiga with prednisone lived 34 months on average. And then it says that men who took a what do you call the word?
Placebo.
Go.
A placebo with prednisone lived 30 months.
Right.
So I mean, that to me doesn't sound impressive. I mean, it's not like the guys that did the placebo lived 12 months. We're talking about the same span of time. Let
me stop you.
Talk about that. Yeah.
Let me stop you.
Okay.
How sick were the people?
How sick were the people?
Yeah, how sick were the people in the trial?
I have no idea.
Well, but don't you think it's important how sick they were?
Yeah.
So, the trials are difficult to evaluate. They show us that they make a difference, but we know that depends when you get the drug. And the less sick you are, the more you're going to get out of it. Now, if you're really impressed with those sorts of numbers, Corey, your dad should be doing chemotherapy because that made a difference of somewhere between 13 months and 22 months. Did you read those trials?
Some of them.
Okay. So that's a big difference, right? Say 22 months versus 4 months. And the problem is that we don't really know. What we do know now is that early Zytiga, as soon as you see the disease, definitely has a stronger effect than 4 months. But correct. Somebody remind me. I think it was 12 or 13 months. What was it? What was it? Latitude came up with. Can somebody remind me? My brain's a little soggy right now. But the latitude study and the stampede study are showing significantly longer periods of survival. But if you really want the best bang for your buck, your dad should be doing chemo.
Yeah, okay.
Because that.
What type of chemo are you talking about? Are you talking about Taxotere?
Probably yes, docetaxel. Right.
Okay.
I mean that's going to give you.
You would suggest he does Zytiga and Taxotere as his next.
I wouldn't suggest any.
His next course.
We don't give medical advice. What I would say is that the studies that come out have said that Zytiga, that early Zytiga and early both the latitude and the stampede. I was just looking. Both the latitude and the stampede studies were really looking at overall survival rather than progression numbers. So they don't give, I remember now, neither of those studies give how much longer people stayed alive without versus the placebo. They measured in a different fashion. But both of
Hmm.
them seem to indicate that, I'll give you one example. In the Latitude study, radiographic-free progression with the abiraterone, the Zytiga, was 33 months, and it was 14.8 months without it. So we know that it doubled the time to when you first saw an increase in the disease through scanning. It doubled it. Now, having said that, we know that the chemotherapy is effective. We know that the Zytiga is effective. Do we know that both together are effective? I'm not sure. I don't think anybody knows. That's why I want you to listen to the discussion between Alicia Morgans and Chuck Ryan, because they address that. Which should you do?
Okay.
Hard to tell. But we got guys on this call right now who fit into those categories. We've got two guys that I can think of, both Neil and Ken, and both of them chose to do chemotherapy first.
Okay.
And so, what your dad, so from your dad's standpoint, I think one of those two is good. I will also tell you that and I'm just reporting what Professor Bill has told us, that he is not particularly thrilled with any of the genitourinary medical oncologists at Roswell Park.
Oh, okay.
So, you're on the Bill. You're with us. Hello. I would not have spoken for you. I just saw you. So, did you hear the background to this gentleman? Are you on mute?
No, I'm not.
Oh, there you go.
No, I'm sorry. I came in a little bit late and I didn't hear it.
So this is a gentleman of age 50, diagnosed age 59, now 69, who had a 3+5 original diagnosis and a radical prostatectomy, and lives in Buffalo, right on the lake, and who chose he did salvage radiation without hormone therapy, and then chose a holistic route for 6 or 7 years. The disease has come back and now appears to be in the pelvis and the sacrum, and he's trying to figure out, this is his son on the line, trying to figure out what should they do next. And we were just talking about options in Buffalo, and maybe Corey, you could share with Professor Bill which doctor it is that you've been seeing at Roswell Park.
Sure. Hi, Dr. Bill. My name is Corey. Nice to meet you.
Hi, Corey.
Hey, Bill. So my dad's oncologist is named Dr. So. I don't know if you know of him, but he's at Sisters Hospital. And we went for a second opinion to Roswell about a week or two ago, and we talked with Dr. Chada.
Okay.
And he basically suggested the same thing that Dr. So is suggesting right now, which is to start Zytiga.
Okay.
There hasn't been any talk of doing chemo or anything right now. They're talking about doing Zytiga. He's been on Lupron since last fall. His PSA last summer was 630 when he had an incident, at the hospital, and they did blood work. And so right after that happened, he went back on his holistic program, and his PSA went down to 200 within a month or two. And then we started up with an oncologist, Dr. Dougherty, and he put him on Lupron. And then over the course of last winter, his PSA dropped to 30. But then by summer, it had spiked up to 90, and now it's around 200. So
Okay.
the next course of action was, the one doctor said, Dr. Chada said he should continue taking Lupron and also do Zytiga. Dr. So said it's debatable if you want to stay on Lupron or not. And then he said he would start, suggest starting the Zytiga.
I would say one thing, Bill. Just hold your thought one second. I will say one thing. I've never heard a doctor say it's debatable whether you stay on Lupron when you take Zytiga. I will say every, because I've never heard that before. Every doctor I've ever heard has always said that you need to continue the Lupron when you're on the Zytiga. That it's
Okay.
significantly.
No, so, Corey, Dr. Chada is my medical oncologist too.
Okay.
And is he the oncologist that said it was debatable whether or not you should, your father should?
He suggested staying on it.
Yeah, okay. I would have been very surprised if he had suggested that there was an option to go off it.
Yeah.
Dr. Chada is a good medical oncologist. I hope, I have some issues with some of the medical oncologists at Roswell Park, but not all of them. And he's, I mean, my experience is a little bit different because, because of my background and because I worked there. And so, he and I have had our battles, but in general, he's a very good oncologist. And I think that his recommendation, I'm sorry?
He seemed very good.
Yeah, and I think his recommendation for your dad to go on Zytiga is exactly right from everything that I know. Yeah.
Right.
Oh,
Have you been on Zytiga? Have you been on the drug Zytiga?
Yes, I've been on it for, I'm not sure. Rick probably knows better than I do. At least 2 years and probably 2.5. I had a complicated history with it. Dr. Chada off it about 1.5 years ago or so, and that was one of the things we had a battle over. But then I eventually won the battle and went back on it. But now it's not losing its effectiveness.
Bill,
so when you say it's losing its effectiveness, do you mean that your PSA is going up again, or is there other reasons that it's not working?
Yeah, my the main evidence is that my PSA is going up. I've had a series of bone scans just last week, and they look pretty darn good. So the only evidence.
So you don't have any bone metastases that you know of?
Oh no, I have about 4.
Oh, okay.
Yeah, I mean you can't, guys. You really can't compare.
Let me just stop you for a second, Bill. Weren't you on enzalutamide?
Oh yes, thank you, Rick. I was confusing Zytiga with enzalutamide. Yeah, I was on Xtandi.
Let me say something.
Yeah.
Let me say something. There probably isn't much difference between the abiraterone and the enzalutamide. Abiraterone came out first. Zytiga came out first with the Latitude study. So everybody said, oh, early Zytiga. Now, and again, if you listen to this discussion that I just posted in the chat window, that again, Peter will forward on to you, or maybe you can join us online. Now what the doctors are saying are early second line, an early second line anti-androgen. So we know a little bit more about Zytiga than we do about the enzalutamide, but enzalutamide just released its results and they were pretty good too. So there's not a lot.
Yeah. You don't think one is better than the other one?
No, everything points to them being comparable. And thank you, Rick. Rick knows more about my kiss than I do. I was just a brain fart. I forgot. But so I was on Xtandi for over the last couple of years, off and on. Did you have trouble getting the Xtandi covered by your insurance? No, not at all.
Because that's one thing that they're running. Because we inquired about both drugs, and they were saying that the Zytiga would be covered, but Xtandi wouldn't. And I was curious what the reasoning on that is. Why they would cover one and not the other if they're okay.
I had no idea, but I would push for an answer to that question.
Yeah.
They should be willing to cover both.
I think for my father, he would prefer to be just on Xtandi because he's had history of not responding well to steroids. And I know with Zytiga, you have to be on a steroid. Is that true? Do you have to be on prednisone with it, or is it suggested that you go on prednisone with it?
Well, it's not absolutely required, but it certainly potentiates the effect. And so, it's a good idea.
Right.
So I would go back to Dr. Chada and tell him that you want to be on, your dad to be on Xtandi, and and to write another letter, to get in touch with the insurance company again, and ask why they're not willing to cover it, and then and tell him to make the argument in the letter, if he sends a letter, that it's it's well established in its usefulness.
Yeah.
What kind of insurance does your dad have?
He has pretty good health insurance. It's Blue Cross and Blue Shield, and then I think it's called Medicare Advantage also is part of it.
So let me make a suggestion to you. It's coming up to the renewal period. So your father's able to switch his insurance between now and the end of the year. I would strongly recommend, this isn't medical advice, so I can recommend this.
No, I understand.
I would strongly recommend that you look at the United Healthcare plan. Invariably, the United Healthcare ARP plans, those are the plans you get through AARP, AARP, are very competitive and much better than the Blue Cross Blue Shield. And I've heard this before with Blue Cross Blue Shield. I've never heard anybody on United Healthcare ever getting turned down for enzalutamide. And my recommendation to you is to go on to the United Healthcare plan for the state of New York that allows you to get treated anywhere. Meaning, if you wanted your dad to go down to MD Anderson or UCSF out of state, there are programs that can do that. I don't know what the cost is. I know what they cost here in Arizona, but I don't know what the cost would be. But they're not that expensive, maybe a couple of $100. Let me say this. For what you would be spending on the doctor next week, you could probably pay for his healthcare supplement plan B and a plan D for 4 or 5 years.
Yeah, okay.
Okay, and
thank you.
You're not going to have a problem fighting with Blue Cross Blue Shield over whether he goes on to abiraterone or enzalutamide, Zytiga or Xtandi.
Yeah.
I want to keep moving along here. Is there anybody else who would like to talk to Corey about his dad's treatment choices, his current treatment choices, the use of complementary medicines, etc., etc.?
Corey, this is Peter. I just want to make one comment. It comes a little bit out of our conversation, and that's you as a caregiver have an important role to play. And one of the bummer parts of this disease often feel a lot worse than the disease itself initially, and reacting to things like Lupron treatment because of the heavy legs and the loss of energy and so forth. You've got to encourage your dad to stick with it and exercise with him. Do whatever you can to kind of keep him going. Don't let him succumb to the idea, the treatment's so bad that I just want to give up and I don't want to do Lupron or I don't want to do Zytiga, because there will be down days and you got to keep the spirits up.
Yeah.
That's important.
What has been your experience with Lupron? How has it made you feel, et cetera? What should I be looking out? Or not Lupron, but Zytiga or Xtandi. What was some of the obvious, effects that it had on your quality of life?
I personally have not been on it. I just did Lupron. I've not done Zytiga.
Okay.
But other people can speak to that.
Bill?
You've got heavy fatigue. Some people do well with it, though.
Yeah.
Corey, it's really hard for me to tell because I'm taking so many other drugs. So I can't
Oh,
attribute
okay.
side effects
Right.
to any particular one. But, you know, I suspect that it's, you know, I'm not suffering from too many side effects, mostly
Good.
fatigue. And
Yeah.
it could be coming, it's probably coming from all of those drugs, but you
Yeah,
know,
I hear you.
every patient's experience is different. And I know that there are a lot of patients that really don't have any
Well,
side effects.
yeah, I was chatting with somebody that said they're on Xtandi and they were having you know, a real noticeable problem with shortness of breath and not being able to get from one room to the next. And they've done all kinds of testing with pulmonologists.
No, boy,
and,
that's not,
you know, and they're
one
not
that
finding.
I think
What'd you say?
Okay, so let me.
I'm just saying they've come.
is not-
I'm just saying they've come to the conclusion that they felt it was from the Xtandi.
Right. So let me just cut in here. Again, it's hard to tell. I mean, we have a gentleman who's not on the call today who's had huge issues with pulmonary shortness of breath, and they've never been able to get to the bottom of it. He did take abiraterone, he did take Xtandi. I've heard about issues around shortness of breath from many people, including Bill, who's complained about it at times. I honestly don't know. Nobody seems to know what the cause is. At the same time, it's certainly something that's related to advanced cancer. So it's very hard to attribute shortness of breath to either Xtandi or abiraterone or any single drug. It's probably listed as a side effect amongst all of them. I really do want to move on because we've got other people.
Can I just one final thing, Rick, before you move on? You should bring this up, the shortness of breath, with Dr. Chadha for sure.
Yeah.
Because, you know, one potential explanation is pulmonary embolism. That's something that advanced cancer patients frequently get, and so
Okay.
by all means, bring it up.
Okay.
So
Thank you.
again, I'm going to put out, because I know that this discussion's been dominated by two or three of us, and I just want to make sure no one else has any other input. Is there anybody else that has any input before we move on?
You know, all I would say, and it's Ken Anderson talking, is that I have, you know, I live in the Southwest. There's a lot of Spanish American people that live here as well. And I have a doctor, well, a good friend that has an acquaintance that's a fairly well thought of doctor from Mexico City. And in the very beginning, which for me was in February of this year,
Hmm.
I was told,
I think you're cutting in and out for us, Ken.
no, I think, yeah, I was told that, you know, stay with the American plan, don't go into Mexico. There's absolutely no cure that you could be sold in Mexico that's not 100% better in the States. I mean, any money that you're going to give for alternative medicine to someone from Tijuana or wherever, I mean, don't get me wrong, I think there's a place for alternative medicine in prostate cancer, but definitely stick with tried and true American kind of
Yeah, I mean,
things
I
to
didn't
work.
see a problem with doing both, though. I don't see there's anything to lose by doing both.
There's no problem with doing both. I don't disagree. I
Yeah.
really don't.
Okay.
I don't.
I would say that there is not a problem doing complementary medicine with Western medicine. But I don't know that we're talking about complementary medicine. I think we're talking about alternative medicine, and I think that there may be a problem with alternative medicine. We have to be really clear to distinguish alternative and complementary medicine. Really clear. It's really important. If you don't know the difference, we could talk about it, maybe not on this call, but on another call. But there's a very big difference between alternative and complementary medicine. Alternative medicine is medicine that you do in place of Western medicine. Complementary medicine is medicine that you do with Western medicine, and you have
Right.
to okay everything with your Western doctor. So I would not take Zytiga, for example. I'm not sure where we're getting a lot of feedback from someone. So if you're not
That was Len, Rick. I just muted him.
okay, it was Len. Okay. So thank you. Thanks, Jay. So
Len, send me a note if you want to get when you want to talk. Okay.
so you just have to be really careful about the use of the word alternative and complementary, and you have to run everything past your doc. But I think that
Right.
Ken's point is really good, and I really want to use this as a segue. Ken, I'd like Neil. Have you been on the call? I know we've talked. I know you've talked extensively with Dr. Steve. Have you actually been on the call before?
I was on the call maybe 2 months ago when I was first diagnosed.
So what I'd like you to do is, if you would just give a short summary of where you are. You know what's happened since we last spoke to you. Maybe the fact that we managed to help you arrange that consult with Dr. Hartstadt, and I'd like to bring up some of your concerns. And Ken, I would really like for you to maybe respond to some of Neil's thoughts. Somebody's got a dog in the background barking now.
Yes, it's me. It's this 14-year-old dog who wants a treat. So let me give him a treat.
Okay.
He's deaf.
Okay.
And I'm his primary caregiver. Here, buddy.
Well,
So
Neil,
he's helping.
we have a special group for caregivers, don't you?
A special group for what? Dog owners?
Caregivers.
Oh, for care. Oh, yes, I do know that.
Okay. Go ahead.
So I was diagnosed. I'm 51 years old and look pretty healthy otherwise. Normal weight and height and everything. Had some back pain. Finally went to the doctor and said, "What's this back pain all about?" Anyway, my PSA was 838. Then I had a bone scan. The bone scan, the way they worded it was innumerable lesions and all the vertebrae, ribs, pelvis, shoulder, hips. Well, I guess maybe one hip. So it's it wasn't a really good prognosis. And went back for another PSA 10 days later, and the PSA was 1,092. And I heard what I guess all of us hear is that when it metastasizes, there's really no cure. So my thought was just be as aggressive as I can be. And, you try to get as much input as you can from a variety of doctors. And decided I was invited to do a study with Emory. It was, I think it was the BEAR study, where you get Lupron for about a month, then you start with docetaxel, and then you either get the study drug or the placebo. And I told them after 2 weeks of debating on it, I said, yes, I want to do it. They said, well, you really need treatment now. We think this is going to delay your treatment. And so they invited me, and then they disinvited me, which I thought was kind of not so nice. But I didn't want to be that guy to push and shove my way in there, especially in lieu of the fact that I'm a Kaiser patient, not an Emory patient. I think part of their disinterest was that the navigation of, the paperwork, the billing, and all that stuff, being a Kaiser person, but that really remains to be seen, and it's kind of water under the bridge. So what I decided to do was go on the 6 cycles of docetaxel, which I had my second cycle Thursday this week. And of course I started the Lupron about maybe 4 weeks ago. And I really don't have any side effects whatsoever. Every once in a while I'll wake up and my t-shirt, my undershirt that I sleep with will be wet. So I'm guessing maybe equates to like a hot flash of some sort that people say they get with Lupron, but it doesn't bother me at all. And so all that's good, but I did get a spike. I should say after my chemo on the eighth day, ninth day, I got a fever, and it was due to the low white blood cells. And so they admitted me to the hospital. I was in the hospital for 3 days. They gave me, of course, everybody's poking you and prodding you seems like every hour or two, someone's in there doing something with you. But every 8 hours, I had a antibiotic infused in me, and I guess that was more prophylactically, just in case I had something. They wanted to rule out having an actual infection versus just having, I think they call it neutropenia. Well, neutropenic fever. I don't know if I'm pronouncing it right, but it's fever that comes from having low white blood cells. So they gave me a shot of Neupogen on day 2, and another shot. It was day 1 or 2, and then another shot of Neupogen. And my white blood cells came up, my fever was gone, and they sent me home, which was great because I didn't like being in the hospital. So now I think what they're going to do prophylactically, and this is maybe someone can weigh in here, is I spoke with Dr. Harstark. I'm not sure I'm pronouncing that right, but Andrea over at Kaiser in Northern California. She's a GU medical oncologist. And I told her what had happened, and I said, I'm going in for my second round. Do we lower the dose of the chemo? What do we do? And she's like, yeah, I would lower the dose around probably 10%. I think they say go like 10 to 20% based on the person. The oncologist I have here, who's a generalist, she said she was going to reduce the dose by 15%, in addition to giving me 3 different shots to start 24 hours after chemo. So you'd take a prophylactic shot of the Neupogen on 24 hours after, 48 hours after, 72 hours after, to sort of boost my white blood count so I don't end up with neutropenic fever again. Interestingly enough, Dr. Harstark, the GU Medoc over in Northern California, Kaiser, in an email response to me, she's like, yeah, we don't generally give the Neupogen shots. We would just lower the dose and see what happens. So you get 2 differing opinions on what to do. Interestingly enough, I had a similar experience where the GU Medoc I saw at Emory, because there's no GU Medocs in Kaiser here in Georgia. Kaiser's sort of small potatoes here in Georgia, so they don't really have the depth of specialties here. But wanting to see a genitourinary medical oncologist, I found one at Emory, saw him as a referral, and he suggested, he was the one who invited me to the trial and then took the invitation away because he thought I just needed to get treated fast and that the trial would slow me down because he had to get some scans and stuff prior to getting in the trial. But in any event, he suggested getting on chemo and prednisone and the Lupron. And I went to the chemo website and read some of the prescribing, and they said it made reference that you take the prednisone when you're hormone refractory. In other words, Lupron maybe doesn't work anymore. So that's when you would take the prednisone. And I think the prednisone is supposed to work on the adrenal gland production of testosterone. And so I called the company. They said it's kind of up to the doctor. Then I had another physician, the local medical oncologist here.
Let me just cut you just.
So anyway, I'm going to jump to the chase. I'm not taking the prednisone. I'm not taking the prednisone with the docetaxel, but I wonder if sometimes if I should,
Well, some places do give it with, and some places don't. And I'm pretty certain there are guys on the call right now. Some have done their chemo with the prednisone, and some have not done it with prednisone. I mean, usually UCSF, they do give prednisone. Other places, they don't give prednisone. It really seems to be doctor's choice. We've actually talked about this a couple of times recently. But what I want to drill down on a little bit is that, I mean, you sent me a note today about, well, what clinical trials should you be looking at? And I think what I said to you, and I really would like to hear Ken Anderson's point on this. And by the way, I do recognize there are a couple of people that have joined by phone, and I'm sorry we haven't welcomed you yet, but we do it right after we finish this segment. What I want to talk to Ken about is, should you be giving the chemo enough time to see where you're going with it? And before you start thinking in terms of clinical trials, is it worth exhausting everything that we know works right now? Like, for example, the second-line anti-androgens, or early on, you know, you're still so early in your Lupron cycle, we don't even know what that's going to do. Because I don't want you to get ahead of yourself, because you can be stressing yourself out over clinical trials when you may be one of these people that is fortunate enough to respond really, really well. And, you know, after a couple of cycles of chemo, you don't seem to be, other than the neutropenic fever, which, you know, I don't belittle at all. It's nasty, and we've got other men on this call who have been through that too. Today, we've got men on the call who have been through this too. But you may tolerate the chemo really well. Ken, what are your thoughts?
I know I don't. You know, I mean, I understand every person takes chemo and goes through the process different. And there's no way around it. I mean, everyone's body handles chemo, handles Lupron. I mean, I think it's pretty amazing that Neil hasn't had a lot of side effects from Lupron. The hot flashes for me were pretty intense the first 2 months. I mean, not only at night, but during the day. I mean, I remember writing in my journal, like, I don't know, 25, 30 times per day I'd get a hot flash. And I wouldn't log them during the evening because I'd be in bed. But the fact is that it sounds like you're handling the Lupron pretty well. And Lupron is one of those things that, you know, my oncologist here in Phoenix, he started Lupron when he started med school. It's the first thing they do today, which I find it crazy, you know, 28 years later, it's still like first line defense. But they have found, without question, they have found that taking chemo, docetaxel up front, pretty close to when you're diagnosed, and I must admit, the advantage is there. It's a small advantage, but it's a significant advantage.
Hey, Ken, I didn't hear what you said. Can you repeat that last sentence?
About chemo or about?
Yeah, about the chemo. You said something about starting to...
I took it really close to, you know, within 3 months of being diagnosed with prostate cancer. And that was because of the clinical trials that they found that people lived longer and their prostate cancer stayed at bay longer if they did chemo up front. So I would continue on the Lupron, but as Rick stated, I would relax on the clinical trials because your doctor did give you advice. For someone like me and you, the fact that a clinical trial, you go on a randomized clinical trial, you may get a placebo. Because I had talked to my doctor at MD Anderson about the same thing, or, you know, maybe 4 months ago, after I'd finished chemo, about a clinical trial where they'd go and remove my prostate, even though I'm a Gleason 9. And, you know, I have advanced stage 4 prostate cancer. I have cancer in my lymph nodes, cancer in 3 areas of bone. So I'm definitely one of the advanced prostate cancer patients. And it takes a while, I must admit, with you being 3 months or 4 months into this. I mean, I'm like 9 months into it, and I'm still having a hard time sleeping. It's going to take a while to get, and you never get comfortable with it, I don't believe.
You mean sleeping you mean because of the emotional stuff or because of side effects?
No, emotional. I mean, my mind just get to the place where it's okay.
Yeah, well, trust me, I don't cry for a week, then I cry for 2 days straight, so I get it.
No,
But
it
I
is
do
what
have a question. I have a follow-up question. One, is this taking the Lupron shots prophylactically? You think that's advisable? And two, and this is kind of more of a sort of an add-on side comment about the clinical trials. I had an old workmate of mine who works for a company that is involved with a new test other than PSA. The company's called New View Life Sciences, NUVIEW. And anyway, they have some tests where it's like they attach something to something attaches to something in the urine. It's supposed to be more accurate than the PSA. But in any event, I told him what I had. I hadn't touched base with him for a long time, and he said, because I'm involved with this company, I know a lot of people. And he knew this guy up in Thomas Jefferson Hospital in Philadelphia, who I guess he's a radiology oncologist, and he's in with he does a lot of research with radio pharmaceuticals and different kinds of imaging and stuff. And he returned my call today, and we had a short conversation about clinical trials, and he knew of some stuff going on. And he knew about even drugs that might be good for me down the road, but they're in Europe. But he said, we could fly to Europe and you could do some, there's a lot of things that you could look at. But he said, for right now, just get through your treatment and give us a call, early next year when you're through. In other words, don't worry about trials at the moment.
And I think that's good. I think that's good advice. There's loads of stuff going on. There are loads of new drugs. There are some test immunotherapy treatments. There are 3 or 4 new second-line anti-androgens that haven't hit the market yet. And on this call, between us, we do know most of what's happening. But what we don't want to do is to get you all confused, nor do we want to get your hopes up. I mean, and we may not need to get your hopes up because you may do really well with what you're doing. I mean, I want you to take to heart what Ken just said, that where he is now, even though it's still difficult and emotional, his mind is so much easier now than it was 3 months into this. And I can tell you that. I know it from talking to Ken fairly regularly, and I hear it. And the anxiety level has reduced significantly. Ken's finished his chemo. I mean, there are some other options. I mean, one of the big things that probably is in your future, which you might not get at Kaiser, is some type of debulking of the primary, some sort of radiation treatment, which is what Ken will tell us about, when we go around in a few minutes, that he's doing right now. There is good evidence that multimodal treatment, which includes hormone therapy, chemotherapy, and some sort of what I call primary treatment, surgery or radiation, is the best way to go. It's difficult to get that at Kaiser. Steve got it because it's Steve, because he was so senior. But most people can't get it. And you, of all people, should be very, very seriously considering switching out of Kaiser, if you can, and getting to a different medical system for next year. I know you're not on Medicare, but by the way, you and Ken are in the same business as well, so you have that in common. Both.
Hey Ken, maybe we can. Ken, what's your phone number, or if you care to give it to me?
Yeah, I can give it to you. You can always reach me also, and I've been talking with a couple, I've recently been talking to a gentleman that lives in Australia, and we talk every couple of days about just new stuff and what's going on, and I can do the same with you. You can reach me through, I can give you my phone number. It's 480-540-8926.
Wait, 540-8926.
26.
Okay, cool.
Yeah.
I'll reach out to you in a few days.
Yeah, you can call anytime.
So what are your thoughts about these Neupogen shots prophylactically? Good? Bad?
You know, I always get it, and some people get it in their belly, this Lupron shot they get in their belly. I don't know about this prophylactic shot. I usually get a shot on my right, just to the right, high on my ass. That's where I get it. And it
No.
doesn't...
Oh, I don't. I hope I didn't say Lupron. I didn't mean that. I meant Neupogen. Because
Neupogen.
I can give myself the shot. It's the drug that's supposed to increase your white blood cell count.
Right.
Oh, yeah. What I had done during my chemo was they put a patch on my arm, the Neulasta patch.
Okay.
24 hours after, I was injected with something that, quite honestly, I could notice the difference as soon as the injection, as soon as it happened, I knew that it happened. Because my white blood, I'm sure my white blood cell count dropped substantially after chemo, and then 24 hours after, I could feel the difference after this Neulasta shot. So Paul Korn, my doctor at MD Anderson, said there was no way in hell that I knew that it was happening, but the fact is I felt different. So I think I did. Maybe it was mental, because a lot of it is. I mean, it could be that placebo effect, but the fact is I felt better after I got the shot. So
yeah, I mean, I didn't really have.
Dennis Correa, do you want to talk a little bit about the neutropenic fever and Neulasta or the Neupogen or whatever it was you got?
Sure. Yeah, I ended up about halfway through my chemo sessions, about halfway through the course, with neutrophil fever and pulmonary embolisms, both lungs, and put me in the hospital for a week. And that's when they discovered what I had. Got the antibiotics, and they also reduced my dose on the chemo and gave me, what else was it for the? Lovenox for a blood thinner to help to dissolve the clots. And then when I resumed the chemo, it was a 20% reduction, and they also added the Neulasta shot. That was before they came out with the thing they can put on your arm or your belly. I had to go back to the cancer center, and they would give me that injection of Neulasta. The only thing I felt from it was some like little shoulder pain from the Neulasta as a side effect, and it was unusual. They told me to try Claritin, which I did, and that seemed to help relieve the pain from the Neulasta shot. But finished the chemo round. I was also on Lupron at that time after I'd started with Firmagon. So now I'm looking at, I've had a progression shown on some PET CT scans, and now the recommendation from the tumor board that reviewed my situation at Mayo is Zytiga with prednisone. So I've just gotten approval from, I have United Healthcare. They approved that, and I'll be starting that as soon as I get it in the mail.
Nice.
Anyone else who's had experience with neutropenic fever and some of the Neutrogena, Neupogen, Neulasta type drugs?
Yeah, my whole concern with it is they're going to give me 3 shots, and I know when I was in the hospital they gave me the first shot, they didn't really notice anything, and the second shot the next day, because you get 1 a day, I think I only got 2 shots. You do feel bone pain, which was, I just wasn't ready for it, but it wasn't that bad. It was just, it was there. And now she wants to give me 3 shots to take once a day, and I don't know if I need 3 shots. I don't mind taking it if I need it, but I'd hate to take more than I need,
Well, I think the answer to that is that you have to have a doctor that you trust. And if the doctor tells you that's what they'd like you to do and you're not certain, then you've got to feel comfortable enough that you trust your doctor. If you're really not certain, you need another doctor. You know, maybe you can follow the advice of Hartstark if you are comfortable doing that. And
well, she didn't. She seemed to say that she wouldn't give me the shot at all, which I don't know if that's. I don't think that's necessarily.
Just that Hartstark and your doctor talk to each other because there's a difference of opinion, and you'd like to get everybody on the same page. You can do that.
That's a good idea.
You know, so but again, you know, you're struggling in Atlanta with Kaiser because they don't have the right doctor for you, and I think that it's really, really important that, you know, for 2018 you set yourself up with a doctor that you are comfortable with, and we can help you find that doctor, but you really have to be in a place where with insurance. I mean, I know Ken's insurance, and he'll talk to you about it offline. He has a very big deductible, but it's easy to go through the deductibles, and once you've gone through it, at least you know what your medical expenses are for the year, because after that, they're going to pick it up. But I can't stress enough that Kaiser, even in California, is not great for advanced prostate cancer. Kaiser in other places, just it's not the right place because they don't know the disease.
Right.
So we've got to move on because we're down to about 45 minutes, and we haven't done a round robin. We actually, I'm embarrassed to say, lost somebody that we didn't greet, so I apologize in their absence. We have one person on the phone who we don't know who that is. If you haven't introduced yourself and you're on the phone, would you care to do that?
This is your usual caller, Sylvester Mayer.
Oh, Sylvester.
Hello, everybody.
Okay. And I think that's everybody. Okay, so I'm going to run down and just see who needs some time today. And then I'm going to skip over a couple of people that we've spoken to extensively. Is Larry Fish back with us or not? Yes.
Yeah, I'm here. I think I dozed off. I'm in Mexico.
How's Mexico?
I'm in Mexico, but I don't need to. I don't have anything I have to say today.
You know, the problem is you've got to stop drinking tequilas at least 2 hours before you come on this call.
I know, it really was. It really is true, actually. It was Kahlua coffee.
There you go.
Coffee didn't work.
Okay. Well, have great fun, and we'll talk to you next week.
Yeah, I'm still here. We didn't go to dinner yet, so I'm still here.
Okay. Dennis, is there anything else you wanted to add after what you told us?
No, that's pretty much where I'm at right now. One quick question, though, about Zytiga. Did I hear in a previous call that they're looking at a possible generic for that early in 2018?
Yes. Yeah, they are.
Good.
Slightly different method. A slightly different method of delivery or dosage or something or the other. Who remembers what it was called? I think it began with a Y. Yeah. Somebody, or Len or Jake or somebody will put it in the chat box and you'll see it. But it began with a Y, and you know, if I can get to it, I'll do it. But okay, Ken, I'm going to just put you in for a couple of minutes because I really would like you to share the fact that you're doing this pelvic girdle radiation. So we'll come back to you. Is Thibaut still with us? No. Yes. No. Okay. Well, the good news is that Thibaut was on the call at the beginning, and that's always good. I'll drop Thibaut on later. Peter, anything for you?
No, nothing else.
Okay. Jake, for you?
Just a quick follow-up to our discussion last week about the metformin.
Okay.
And I can say it now. I went to my doctor yesterday, and I got 1,000 milligrams without any problem. She said, okay, no problem.
All right. Okay. So the lesson
I told her.
is advocate for yourself, Jake.
Yep.
Good man.
I told her what I wanted, and she said, that sounds good to me.
Okay. Well, let's see how it does on your next round of blood tests, and if it does some of the things that we'd like it to do. That's great, Jake. Okay. Len, anything for you? You want to talk about anything in advance of your doctor's appointment tomorrow?
Nothing really, Rick. I can tell you this much.
Hold on, guys. Guys, I just want to know if you want to speak or you don't, because everybody wants to sort of talk, and I got to figure out how many people need to talk.
Then I'll pass.
Okay. Well, we'll come back to you because there is something that's on your mind. Paul, anything for you?
No, nothing for me tonight. Thanks.
Okay. Bill, anything you'd like to review?
No.
Okay. So we do have, we're going to have plenty of time. So let me hit on Len. Go ahead, Len.
Oh, well, very briefly. I do have an appointment with my oncologist tomorrow. Last week I got a PSA result of 0.41, which was up from 0.34 6 weeks earlier. So I'll have a discussion with him on whether or not I stay on drug holiday or if he wants to do any scans. I think it would be a little early for scans, and PSA would have to go a little higher. That's it.
So, you know, the question is, so let me just make a note here. So the most recent PSA was 0.41, did you say, Len?
Yes.
And the one before that, I've got one at 0.21 back in July. What was the one before your 0.41?
0.34.
And that was when?
That was last week. Oh, no, I'm sorry. That was 6 weeks ago. I don't know the exact date, but I know we were doing it every 6 weeks.
Okay, so say that was August.
Yeah.
And that was 0.34, right?
Yeah, so slow upward climb.
Right. And, you know, I'm really glad that you're describing it this way. It's a really important thing for guys on the call to hear, because how many guys have we heard on this call that say, oh, my PSA doubled between July and October. It went from 0.21 to 0.41. It did double mathematically. But I think that Len's attitude is the right one, that you really got to be recognizing it's at pretty low levels, it's creeping up, and Len would expect it to creep up because he's on a holiday, he's on a Lupron holiday, and we know that's what happens on a Lupron holiday. And the question is, you've got to come to some agreement with your doc how long it is that you can stay on that holiday. Len, have you had any discussions with him about that today?
With my oncologist?
Yeah.
No, I see him tomorrow.
But before that, have you had any discussions with him about how long you'll stay off? And what?
No, he didn't give me a target PSA at which he thinks I should either be scanned or go back on hormone therapy.
Okay.
He didn't specify any particular value.
Now let me throw that one open. It's a really good one. Who else has had the opportunity to do intermittent therapy, and how have you approached when you're going to go back on hormone therapy?
This is Jake, Len. I tried it, a couple of years ago, and I agreed with my oncologist. She didn't think it would work for me because of my case, but she agreed to try it. And originally the threshold was either 10 or new pain. So or new symptoms. So I made it up to about, I think, 6 or 7, and I started having some issues, so we went back on it then. But I certainly wouldn't panic at 0.2 to 0.4 if I were you. I'd give it a little bit. I'd give it a little bit of time.
Yeah, I'm not at all anxious about it. I'm a Gleason 9. I expected it to rise. Actually, I'm happy that it's rising as slowly as it is.
Peter?
Yeah, I'm even slower. I haven't even reached 0.1 yet, but I'm going up 200ths every month or so. So I'm at 0.08 right now. I met with Dr. Turner a month or so ago, and we talked about that. We didn't come up with a specific number, but we agreed that I'm going to test every month and just really keep an eye on it. And if I see something jumping or if we see something abnormal, then I'll either go back on Lupron or I'll advance to Zytiga. We talked about that a little bit, and he's open to either one, but he says if staying on a holiday now works for you and you feel better, go for it.
And anyone else ever done a Lupron, ADT holiday?
Well, I did one previously, Rick.
That's right.
Before my radiation, and at that time, over a period of 7 months, I went from less than 0.2 to 10.9. So now, these past 7 months, the second time around for intermittent, I've only gone, as you said, something like 0.19 to 0.41. So that's much better, much slower rise than last time.
Right. So, one thing we might be able to attribute to that is the radiation treatment, huh?
Oh yeah, for sure.
Okay, well, I don't want to milk this too far, but it's a question that comes up. It comes up a lot on the. I'm sure those of you who are still very active on Inspire and some of the other blogs, you see it all the time. How long should we stay up for? When should we go back on? And there's no answer to it, and so I just thought it might be an idea to air it here and what anybody else has. Anyone else want to contribute to that conversation? Okay.
Just one additional comment. When I did go off of it, I didn't last very long. But when I went back on it, my PSA on Lupron, my PSA plummeted back down to 0.5 again within like a month and a half.
Wow.
So it does work. I mean, it does work again.
Right.
At least it did in my case, and it probably will in yours.
Jake, were you off it long enough to feel better?
No, I only made it about 6, 7 months, and my testosterone started going up, but I didn't notice any difference, a whole lot of difference.
And Len, you've been off since April, correct?
Correct.
And do you feel better?
I do, much better. Feel much stronger, more energy. Yeah, that's why I do it.
Right. Right.
No hot flashes.
Right. Right. I mean, it's great that you respond so quickly. I mean, I think it's a terrific strategy for somebody like you who really gets the benefit out of it, whereas you take somebody like Jake, he's not getting as quick a benefit. So then you say, well, is it really worth it?
Yeah, I agree with that.
In particular,
Leonard, you get testosterone checked every time you get your PSA checked?
Yes, and it went from less than 4 in April to over 700 now.
Wow, that is terrific that it came back so quickly.
Yeah, it did last time also.
That is great, because we've got guys where the testosterone just doesn't come back that quickly.
Yeah, I know a few in my local group.
Yeah. So
I don't think mine ever was at 700. So we have a real macho man on our hands here.
You need some Italian blood, Jake.
That must be it, yeah.
That French blood, you know what they say about those Frenchies, don't you?
Well, they don't have much testosterone, apparently.
Okay. All right. It's good that we don't talk about intermittent hormone therapy that often on this call, but you know, for some people, it is a good plan. I mean, but I will also say that when they did the original studies, Maha Hussein back in 2012, they seemed to think that it worked better for people that started on hormone therapy as their initial treatment, and not for people that had recurrent disease. Well, I guess, Len, you did start on it as your initial treatment, didn't you?
Yes.
So, you know, it's I don't know why, but that was the conclusion that those Maha Hussein studies came to, as I remember them. I hope I'm not.
Yeah, and you know, it's a good point you raised, Rick, that there you had a clinical trial that for intermittent ADT, and their conclusion was, well, you know, on average, it really didn't benefit guys. They still had the same symptoms as when they were on ADT, and yet here I'm an example of an outlier. So I mean, you can't always look at a clinical trial and say, oh, well, there's really no benefit to going on intermittent. You never really know unless you do it yourself.
Yeah. And I think, you know, it was always, well, do men do as well on intermittent as they do by staying on the drug? And they said, well, for those men who started on it, it doesn't seem to have any adverse effect, but the benefit is that they have much better quality of life. For men who have recurrent disease where they've had to go on to hormone therapy later, then intermittent isn't as good as staying on the drug all the time. That's I think what the result of that study was. Okay. Any other comments before we move on to Ken? So I really want to give Ken a little bit of time because for me, Ken's a bit of a star in that he's doing something that I certainly didn't think, well, I'd never heard of before, which is, I don't want to say it didn't make sense, but I'd never heard of anybody doing it before. And so I questioned it very, very seriously. And Ken, maybe you want to talk a little bit about the treatment that you're going through right now. It may be beneficial to some others on the call.
Well, I don't know if I can make it any beneficial. It just is what it is. And I did talk to Paul Korn about doing IMRT versus SBRT. And his comment to me was, you know, that it would not hurt. And he could not see any reason other than the inconvenience, which he said he understands. You know, there's many more trips down to have radiation, but his comment was, you know, that doing, as you state, pelvic girdle radiation versus just prostate radiation to try to do something about the primary cancer, he didn't think it would do any harm. So I'm going to stay the course and go ahead. And I talked to Lucas here in town, you know, that today actually, because every 5 days is I sit down and tell him kind of where I'm at, what I'm thinking. And today was that day. So I'm pretty much okay with what I'm doing. You know, I'm not going to go look around for another oncologist to give me SBRT or something CyberKnife-ish in 5 rounds. I'm just going to drive down every day for the next 2 months and have a little dose of radiation and try to kill as much of the prostate cancer that's in my prostate and around my prostate bed as I can, in the hope. And the indication was that I should see my PSA go lower than, at the moment it's 0.8. I had a little rise for whatever reason during the last cycle or test from 0.6 after chemotherapy to today. And I say a little rise, it may be crazy because in my head it went up 25%, but after discussing with Korn and you, Rick, I kind of came to the conclusion that it was a little rise. So, and we'll see where I'm at in another 20 days because that's when I get my PSA test again. I'm definitely not mentioned. I'm not more comfortable with what's going on. It's just the timeline. I mean, I sleep like crap. I don't sleep more than 3 or 4 hours a night. But it's just what it is. You have to figure out a way to get around that part of having prostate cancer. You have to rest when you...
A couple of things, Ken. I'll come back to the sleep, but I just want to be sure the guys understand what it is you're doing that is so unusual. It's unusual to debulk the primary tumor. It's only something we've been seeing happening recently. By recently, I would say probably the last couple of years. Before that, Mayo always debulked, usually with surgery. I say always. I would say, 80, 90% of the time they recommended surgery, even if you had advanced disease. Whereas most other docs, in the spirit of doing no harm, felt that there wasn't any point in debulking. And Memorial Sloan Kettering ran a trial, which I'm going to try and post in the box in a second, where they found it was very beneficial to do multimodal treatment, and as part of that, they did surgery on 20-odd men. And it seems that since that trial result, which was run by Howard Scher about 2 years ago, I think it is now, we're seeing more and more practitioners, GU medoncs, recommending that it is worthwhile debulking the primary tumor. Debulking means taking out that lump of cancer that we know started in the prostate. Now, some of you will remember that Dr. Steve did this at Kaiser, that we convinced Joe Song, the head of radiation oncology for Northern California, and Steve did a SBRT treatment. And we've had other guys that have recently that have done this treatment. However, none of them to date have had their whole pelvic girdle radiated, which is a standard treatment for men with more advanced disease. It's what I got. It's what people like Mac Roach are renowned worldwide for promoting pelvic girdle radiation, as well as radiating the prostate. And I had never heard it done for chemotherapy, with chemotherapy, or after chemotherapy. So what Ken is doing is pretty much, to my knowledge, it's really groundbreaking. I don't want to say it's a first, but it would be interesting to post it on Inspire and see if anybody else, or on Healing Well, see if anybody else has done it. So that was what I was referring to. And then the other part of that discussion was that I said to Ken that he could do the focal gland radiation in 5 visits if they had the right equipment, as Steve did, versus 20-odd visits. I will say at the time that was because Mr. Anderson was complaining to me about having to drive that far early in the morning. So, but he has become more sanguine about that. I think he must have put new music on his iPod or something. don't know.
Well, the whole thing for me is that if in fact debulking the primary is effective,
Yeah.
then why in the heck is not debulking the primary plus any lymph nodes that are located around the prostate? I mean, I don't know that the outcome is beneficial. I don't.
Mm-hmm.
In my mind's eye, just as I told Paul, you know, I can't but imagine taking the primary cancer away isn't beneficial. And that's kind of the start of the whole conversation about, you know, doing something with the prostate. But then to push it a little farther, I can't imagine doing something with cancer located within lymph nodes wouldn't also be beneficial. So it's a little inconvenient. I understand that. But I mean, my life has changed like nothing in my life. So, I mean, what's a couple trips? I don't know. I'm okay with it. You know, mentally I'm okay with it. So I'm gonna continue.
I have I put the reference. It's from Science News and it's to the Howard Chair study on multimodal. I have one big problem with it. It talks about cure, and I think it's a bad representation. I do have the study somewhere. I know. I remember I saved it, but I can't find it right now. But the study's reference. But this Science News article says that, you know, they found a new cure for advanced prostate cancer. The reason I have a problem with it calling it cure is because this study, which I think came out last April, said that after 20 months, men who had done a combination of surgery, radiation, and hormone therapy had no sign of prostate cancer. Well, as most of us know, 20 months is a little early to judge. And if they came with that result after 10 years, they may have a case to use the word cure. But I think the cure is editorial license. So anybody who's just clicking on that link that I put in the window, I'm not endorsing the use of the word cure in there. Anybody want to chat with Ken about this treatment, this radiation treatment he's going through now? When did you finish your chemo, Ken?
I finished it about 6 weeks ago.
Okay. And do you feel...
Go ahead.
I was going to ask you, do you feel you've recovered significantly since you finished the chemo, or do you still feel the chemo?
Well, you know, I definitely 5 weeks ago said I felt pretty good, you know, and then I started radiation. So, I mean, I do have a little bit of neuropathy in my left foot, and that may or may not go away. I don't know. I mean, all in all, though, I mean, don't get me wrong, chemo in general was not a fun process by any stretch of the imagination, but I do know that it took, you know, my PSA substantially low, which I'm hoping radiation does a little better. I would say chemo is definitely something I would do again if I need to, and I probably will need to at some point.
Yeah, Ken, this is Neil in Atlanta. Just a question as to your healthcare provider and where you're getting the treatments.
Okay, my healthcare provider is Blue Cross Blue Shield and of Arizona. So I lived around here in Phoenix, Arizona for a med-onc that was someone that I liked, and I didn't find one, so I ended up going to MD Anderson in Houston. And Blue Cross Blue Shield does and has covered, you know, 100% after my deductible, which is a monster of a deductible, but that was my choice 10 years ago or 8 years ago. You know, my medical insurance kept going up, and I'm an independent contractor or self-employed, and I opted at that time to consider medical insurance you know, kind of like disaster insurance. You know, I figured I could pay for the little incidental stuff to keep my monthly expense as low as possible, and as it turns out, you know, I was 3 years short of what my anticipated. I mean, I thought after 10 years I'd be doing fine, but also I didn't think I was going to get cancer, so I don't know. I mean, I definitely have a high deductible and I have a high copay, but after that's covered, you know, they cover 100%. At least they have.
What is what is your deductible and your monthly?
Well, with Blue Cross Blue Shield, and I must admit, I took Blue Cross Blue Shield, I hate to say now, but maybe 28 years ago. So when I first started, it was $187 a month. Today, it's $500. My deductible is $10,000, and my copay is maximum annual out-of-pocket Jan 1 to December 31st, $4,000. So my maximum out-of-pocket per year is $14,000.
And that's just you, or you and a family?
That's just me.
Okay.
So not inexpensive, you know, but it is what today it's $500 a month plus $14,000. You know. But I'm sure as hell glad I have it because I was real close to canceling it all.
So,
excuse me.
One thing that I would suggest to all of you fellas that are well under Medicare age, if you have metastatic cancer, is to be sure that you apply for SSDI, because once you've held the SSDI for 2 years, you're automatically eligible for Medicare, no matter what your age. And you can backdate to your date of diagnosis or a negotiated date. So
I know, Rick, the only problem is that you have to have no income.
no, you don't have to take the money. You can register, you don't have to take money from them. The money and the Medicare are separate.
Oh.
So just by registering and being accepted, you can decide that you don't want to take the payments, but it still starts counting down on your eligibility for Medicare.
All right, I understand.
Okay, so I recommend everybody does it. I was lucky enough to get SSDI, and I think I had, because I waited and waited, and I thought, oh, I don't need it, I don't want to be on SSDI, but I was in such a state after about 18 months that friends of mine said, you really should apply, and I did, and I got it, and I think I only had to wait about 5 or 6 months before I got my Medicare. And the difference for me was that my payments went, and I was on Kaiser, my payments went from $800 a month down to $200 a month. And that's...
No, I understand. Huge savings. I don't disagree.
Right.
I better get really. I mean, I've done it twice. I've gone through the process of started, and then I just put it on the back burner because I've been moving. So.
But you may not have lost anything because you can still backdate your date of diagnosis. Now, you know, as far as the money's concerned, Ken's right. If you earn over, I think it's $25,000 a year, you have to start reducing that from what they pay you. So, you know, if you're making a good living, it probably isn't worth it. The only thing is that you can backdate it. So and they'll give you that much in a lump sum, but I honestly don't know if they ask you what you earned during those years. I can't remember that much.
You know, this is Neil in Atlanta. I applied for it, and I think the amount you have to earn is like if you earn more than $14,000 a year, you don't qualify. But to your point, they don't mention the fact that you still ought to sort of throw your hat in the ring and get your date set. I'm almost of this opinion of hiring an attorney to do it for me, because they ask for all this stuff. Then when you call your counselor, or whatever they call it, the caseworker, they say, well, you have to wait at least a year for us to know exactly what you have, and it's really sort of confusing. I can't imagine an attorney would be that expensive to handle all that for you. But I don't. Does anyone have any experience with that?
Yeah, I do. Two things. First of all, don't confuse SSI with SSDI. I think that $14,000 limit is SSI. I think.
It is.
SSDI is different. So you want to be applying, if you're earning money, you need to be applying for SSDI. All that is going to do is accelerate your Medicare, and also, if you want to take it, accelerate your what you would have otherwise received at age 65. And what you receive at 65 is then reduced by a certain amount according to how much money you're actually making over $25,000. And it sounds to me, Neil, that what you're talking about is SSI, which is different.
True.
I think it was SS. I don't know what it. That's why I think I need to get an attorney to do it for me. I can't be bothered with it.
Well, you ask about attorneys. I did my own application. I put it in. I mean, it was a bit of a pain to do, but I did it, and I got turned down. And when I got turned down, this was for SSDI. Then I hired an attorney. The attorneys are restricted in how much they can take. I think it's 15% of whatever you get up front. So, you have to find an attorney. You've got to talk to them and see. But there are attorneys who will handle it for you. But I strongly recommend for you guys that want to get onto Medicare sooner rather than later, I would not delay on, and you qualify automatically. So I don't know what these people are talking about, because you have you are what's it called, compassionate something. You get on immediately. For SSDI, you qualify in 6 weeks. If you haven't.
Yeah, well, they kind of sing a different tune when you get them on the phone. That's why I think.
Yeah, I think you're asking for something different, though.
I mean, it was SSDI. I told him I want disability insurance. I even said to him, I want to get the Medicare after 2 years and yada, yada, yada. And,
yeah, but there are
they're like,
different types, Neil. There's SSI and SSDI, and they're both disability insurances.
Okay.
Okay? But the SSI gives you additional payments, and you're not looking for additional payments. You're just looking
right.
That's
to accelerate.
That's limited. That's the one that's limited to 14,000.
Right. I think you're applying for the wrong one.
Maybe.
Well, you have to apply. Well, it might not be the wrong one, Rick. It's just not something. If you make more than 14,000, you're eligible for.
Right. I'm sorry. I misspoke. But I think that the one you want to be applying for that will allow you to start ticking off your time for Medicare is the SSDI, and that you definitely qualify for under this compassionate.
But again, you're not going to be eligible if you make more than $28,000 or $24,000 a year, or it's deducted from what is. I mean, I'm not exactly sure how it works, but I know if you're still employed and still work and want to continue to work, what it does, it just allows you to take off or tick off the box that you've waited the 28-month requirement.
Right.
That's all it really does. Right. Until you need to take it.
Okay, so I'm putting two links in the chat window. I just put one in, which is about the compassionate. Hold on a minute, and I'll tell you what they call it. They call it compassionate allowance. And then I'm putting in another link. These are both off of the site. I'm putting this in right now, which is applying for Social Security with prostate cancer. So both of these come right off the site. And they will explain it probably better than I can, but I can pretty much safely tell you that that with both of these, you will you'll find that if you don't want to take money, but you do want to start ticking off your time, you can do it, and you would be approved for that within 6 weeks.
I think you had sent me that once, Rick, the prostate cancer thing out of SS, whatever it was, their workbook. And on there, it's a little misleading because it says something to the effect of metastases to visceral tissue, not just to bone. And I guess the assumption is if it's on your bone, it's also in the visceral tissue, but I don't know how they define that, or even if they do.
I think it's you can correct me again. Take a look and correct me if I'm wrong, but I think it's bone mets. It's bone and visceral.
Yeah, it's when you read the wording, how it's phrased on that one page, you could argue either point of that argument. You could raise the argument for or against.
Well, but let's make the glass half full, Neil, because I know so many guys that have done this.
Yeah, absolutely.
You know, and they've gotten approved, and they've gotten approved very quickly under the SSDI compassionate allowance.
Okay.
Yeah, I'm one of those. I'm one of those people. I'm on SSDI. I went on within 6 weeks, and it was on the basis of bone mets. There was absolutely no problem.
Right. Thank you, Bill.
Thanks, Bill.
I think it might be a good idea to go to a Social Security office, so you're sitting down face to face with someone rather than talk on the phone.
Yeah, I did that. I was in there for like 3 hours, thought it was all squared away, and then somebody called me like, "We need to get your jobs you had 10 years ago." I'm like, "Really?"
Yeah. Well,
I was like, I don't even.
They do need to do that, Neil, and it's a pain in the ass. But what's a bigger pain in the ass? Paying $14,000 a year out of pocket and $500 a month, or paying a couple of $100 a month? I mean, they're not going to put it on a plate for you, but yes, you have to jump through some hoops. Let me read.
Oh, I jumped.
Let me read.
I did what they had asked, and it was just, it wasn't quite enough, and it's fine. I'll keep going down that road. I just figured attorney would be better.
I said to you, it's a pain. I did it too, and Bill did it. It is a pain. You got to, where did you live 10 years ago, and who were your doctors 10 years ago? It is a pain, but that's what you got to do if it's important to you. If you got the money and you don't care, forget it. Let me read the description because I'm looking at it. Prostate cancer hormone refractory disease occurs when the cancer is recurrent, comes back despite hormonal intervention, or the cancer has spread to the bone or visceral organs such as the liver and lungs. So it's very clear that if you have cancer in your bone, even if the disease isn't refractory, then you qualify.
Okay.
Okay. How about that? 5 minutes to go. All right, guys. Anyone else have any input on applying for SSDI, SSI?
This might be a great plenary session topic if we can come up with someone from Medicare that wouldn't mind speaking to us sometime on a fifth Sunday. That's coherent and we can.
The only issue is we'd have to widen it because it doesn't really interest the guys that don't have advanced disease, Peter. So I think that maybe the topic might be sort of Social Security, and then we could cover it within that, but I'm not sure we would want to cover it in a plenary that was, open to the guys with low-risk disease, because it wouldn't really be appropriate for them, don't you think?
Right. Or just insurance in general. We could maybe have a small panel with perhaps someone from healthcare and someone from the government and whatever.
That also reminds me of something else I was going to mention to Ken. Ken, you talked about the trouble with sleep. You're having trouble sleeping. So this fellow that I'm becoming friends with, who lives here in Tubac and is a associate professor at the University of Arizona in the Integrative Medicine Center. I mentioned him earlier. He is a nationally recognized, world recognized expert on sleep. He's a psychologist, a PhD psychologist. And he's been at the Integrative Medicine Center for years and years and years. I mean, he's one of Andy Weil's original guys. And he does, he consults on sleep. I don't know what he charges. It's probably negotiable, but you know, it may be that he's the sort of guy that if you're having sleep problems, anybody here having sleep problems, if you write me, I'd be happy to give you his name and a referral.
All right, will do. You know, I can honestly, after chemo, after I finished chemo and maybe a little prior, I'd kind of gotten comfortable with it and was able to sleep without taking, I think it's called Xanax or whatever the drug is that they've given me to assist kind of knocking my butt out at night. But just recently, you know, and I know it's partial, part of the problem is I'm moving out of house.
We're losing you, Ken.
I know. Anyway, I'll take the guy's name and give him a buzz.
Okay, I'll send it to you, but for everybody, and you can look him up because he's easy to Google. His first.
Rick, can I speak to that sleep issue?
Let me just give you the guy's name. It's Rubin, R-U-B-I-N, Naiman, N-A-I-M-A-N. And he has a website and goodness knows what. So yes, please speak to him.
I'll Google him. No, I honestly don't think talking to someone about all the issues in regards to having cancer and trying to get my mind mentally kind of get comfortable, if at all possible, is not a bad thing.
Yeah, who wanted to speak to it?
I did, Rick. Len.
Yeah, go ahead, Len.
Right. So you had also given me this guy's name. So I happen to know that his fee is $200. I don't know if that's an hour or per session or what. But the other thing I wanted to say to Ken is that I was having issues not falling asleep, but staying asleep. And I would get up in the middle of the night to pee, and then I'd find I had a very difficult time getting back to sleep. For me, what worked is medical marijuana, a CBD strain, which there's no high associated with it. You take it right before you go to bed or an hour before, and that worked fantastically for me, still does. I sleep solid right through the night, except for the one time I get up to use the bathroom. So that's something you might want to look into, assuming medical marijuana is legal wherever you are.
It is. It is. I actually have marijuana sitting here on the counter. I've never smoked it before. I don't know how to do it.
Well, yeah, you don't want to be smoking high THC content marijuana because probably will interfere with your sleep more than help you sleep. But yeah, you should go to the medical marijuana clinic or doctor and just tell them you need it for sleep, and they'll set you up with the right stuff.
Would you call it THC?
No, well, what you want is CBD, cannabidiol.
CBD.
Yeah, that's like C as in Charlie, B as in boy, D as in David.
Oh, I got it.
Yeah,
okay.
CBD. Mm-hmm.
So there are, first of all, there are, I think, some references, some links on the website. I think there's a link to Don Abrams from OSHA Integrative Center at UCSF talking about medical marijuana, and it's it's a good program. It was a cure talk, and he explains it very well. There are essentially, as Len said, two elements, CBD and THC. You want one that's heavily weighted towards the CBD and not the THC.
Gotcha.
The other thing is that there are ways to take it. I wouldn't smoke it, maybe ingest it or use an inhaler. You can buy these inhalers where it burns it, and then you take it in through the inhaler, and it softens it quite a bit. And you'd find those in wherever you buy your medical marijuana store is. I know there's one in downtown Tucson. So I absolutely endorse what Ken is what Len is saying, and I strongly recommend that you look up you listen on our on the website to the. I'm pretty certain it's there. If it isn't, I'll check afterwards. If it isn't, I'll put it on there, or I'll send you a post. I'll put it on there when I post this site, when I post this talk. As far as Ruben Nyman and his fee, first of all, it is covered because he's covered by insurance. So if you're through your deductible, you'd probably be 100% covered for him anyway. And secondly, he did mention to me that the $200 was discussable. So, if you guys don't have insurance, you're paying out of pocket, he's willing to talk to you. And he knows what I do, and he's very empathetic. So, so don't let the $200 scare you away if you think you might want to do it.
Avi, can I just say, I don't know if this is a chronic problem that happens every night or not, but I occasionally have trouble sleeping, and I just pop a Benadryl, and that really works. I'm not sure I would want to do it on a regular basis, but it does, when I occasionally have difficulty sleeping.
Mm-hmm.
I was told to take Benadryl at night, and the person that told me said that it worked for them, and I tried it, but what I found is that it restricted, and maybe it's just me, but
I missed that. You're cutting out again.
No,
Can you say that again?
No,
I'm not hearing anything.
we lost you. Sometimes you're clear as a bell, and then we just lose you. So I don't know. One
of the side effects of Benadryl is it can cause urinary restrictions. I think that's probably what Ken was saying.
Oh, okay.
Is that right, Ken?
That's correct.
Okay.
So I just have to do it, after I go to the bathroom.
Okay. Ken, on the web page that says recordings and decks, where we post the calls, under recommended webinars, there's a section that says Complementary Medicine, and the fourth title down is Cannabis for Cancer, Donald Abrams and the Panel. And that's what I recommend you listen to. It's already posted.
Okay, will do.
Okay. All right. So we've run a little bit over, but it was worth it to talk about these sleep issues. I think Ruben's going to do a plenary for us on sleep next year. Our next plenary coming up on October 30th is going to be with Donna Wilson from Memorial Sloan Kettering. She runs the exercise program there, and which Len attends, and also Richard Foodie. And she's agreed to talk to us on, which should be great. She's good, isn't she, Len?
Yeah, she is, and I'm going to see her tomorrow, and I'll make sure she has that on her calendar.
Okay, and if she has any slides she wants to use, if you can work with her to make sure we get them so we can post them for those people that are going to call in, because for sure, even though under our new handy-dandy go-to meeting we can put 50 people in the room rather than 25, there'll still be people that are calling in that night. So they may want to download if she's going to use a slide, there.
Yeah. She is excellent. I highly recommend listening to her.
Right. Okay. All right. The other thing I just wanted to mention, I know that this is a very rare disease, but if you know anybody with male breast cancer, we are starting a male breast cancer call. I think the first session is going to be November 2nd. I clearly will not be moderating that. I'll probably be giving them a little technical help up front, but we do have expert moderators that will be moderating peers that have the disease. And if you write to me, if you know anybody and you write to me, I can make sure that they are put on the list for the advance notice for that call. All right, guys. That's it for tonight. I will speak to you all next Tuesday, I think, right? No, next Monday. Monday.
Monday at 8 o'clock.
Monday at 8 o'clock. Thank you. Thank you for keeping.
Thank you, guys.
Okay.
Thanks, Rick. Appreciate it.
All.
Thank you very
Thanks,
much.
Rick.
Good night.
Bye, guys. Thanks, everybody.
Take care.
Okay.
Good night, guys.
All right.
Hi, Jake.